Hey guys, welcome back. The topic that we're going to study now is mitral regurgitation, and I'm going to first talk about why is it going to develop. We're going to talk about the causes, and I'm going to subdivide this into the acute and the chronic variety. The chronic variety would be thanks to MVP. The mitral valve prolapse contributes to a late systolic murmur, but in the long run gets converted into a pan-systolic murmur. So I'll be hand drawing those murmurs before you. But do remember the statement chronic primarily is MVP. And now let's look at why would you be having a acute variety coming up also. The first and the foremost reason would be infective endocarditis. You see the vegetations which are going to be present here, let me say due to Streptococcus viridans in Sabe, is damaging the chordae tendineae, and if the infrastructural support on the undersurface of the valve is damaged, the valve will not be able to retain its position. As a result of it, a variable amount of blood can leak across from the left ventricle into the left atria, contributing to extreme amount of congestion in the left atria, and the same pressure will then be transmitted to the pulmonary circuit, contributing to pulmonary edema in these patients as well. In some cases, however, it may not be that the chordae tendineae are damaged. Rather, what can happen is damage to this support of papillary muscles. So let's look at the second reason. Why would you be having this acute mitral regurgitation developing? And as I said, it's a papillary muscle dysfunction. Papillary muscle damage can be occurring due to ischemia. So it could be most of the time a myocardial infarction that can cause acute MR. Most of the time it is the posterior leaflet, though any of the two leaflets can be involved. Usually what we see is that the posterior leaflet is more commonly involved as compared to the anterior leaflet, and the importance of knowing that is only that the jet of blood that's going to develop with the posterior leaflet damaging is going to move anteriorly. That's primarily because of the fluid dynamics that come into the picture, whereas if the anterior leaflet is damaged, the jet of blood tends to move posteriorly. Point number 3 needs to be listened with lot of care. You see, earlier I was saying that MVP, the myxomatous degeneration, is one of the leading causes of MVP, contributes to chronic MR, and now I'm going to talk about MVP even in the acute mitral regurgitation. So the query from most of the doctors is that on one hand you said that MVP contributes to chronic MR, then how come in acute MR also you're saying the same thing? Well, the point is MVP can occur again not only due to myxomatous degeneration, it can also occur on an acute basis. One of the important reasons where you could be having a chordal rupture is Marfan syndrome. So what I'm writing here is not the word MVP, but it's a variant that I'm writing here, that is flail leaflets, because after all in MVP you have leaflets which are not having architectural support. So the message is myxomatous degeneration is a ultra slow process. So that's why I said chronic. But if MVP is occurring in the acute format, yes, it can contribute to acute mitral regurgitation as well. And the fourth reason would be blunt trauma. Now, for blunt trauma, I want to say that at various sections in the app, I have talked about situations where, let me say, we are talking about a mixed martial arts fight and this boxer gets punched in the chest. So, one of the reasons why blunt trauma to the chest can contribute to death is commotio cordis. And what happens in this case is that the punch landed right in the middle of the T wave. Middle of the T wave in the ECG is called as the vulnerable period of the heart. So if there's any external influence, electrical influence, there was a solid impact. So this impact per se can contribute to a triggering of a arrhythmia, and this commotio cordis can contribute to development of sudden cardiac death. Another case can be a guy is driving a car without a seat belt on, and he has a deceleration injury. The chest slams into the steering wheel. So there can be a cardiac tamponade developing, and the pressure on the heart will contribute to the intrapericardial space pressure being more than the left ventricular end diastolic pressure. So less blood will come in the heart, less will go out. So I'm talking about cardiac tamponade. But today I'm teaching you the fact that blunt trauma to the chest can also contribute to development of what we are studying at the moment, the acute variety of mitral regurgitation, which can contribute to acute pulmonary edema. You see, when a patient with blunt trauma to the chest is brought into the hospital, you are not aware that he has sustained a development of caudal rupture, which is contributing to acute pulmonary edema. And because he's having a low BP, you might actually erroneously, I'm saying erroneously give IV fluids to this guy. And anyway, in trauma cases, we tend to give IV fluids and the pulmonary edema will worsen. So most of the time, this blunt trauma contributing to acute variety of MR gets or goes undetected. And once it goes undetected, then in those circumstances, I mean, if you give fluids, the person will anyway die. It will rather expedite the mortality of this patient. So we have worked out the important causes for acute mitral regurgitation in a patient. We'll talk about the murmur part also, but before that, I have another job to do, that is to tell you regarding why would a patient be having a chronic MR, and I'm gonna subdivide this further into two parts. That's gonna be primary and the secondary variety. Now let's look at what do they mean by the word primary and secondary. Primary implies the fact that the leaflets of the valve are having a disease, or the structural support which is given by caudate and DNA just below the leaflets are having some disease process or pathology. Whereas when it comes to secondary, it is an annulus dilatation. Do remember the fact that this annular dilatation can sometimes also be written as functional. Like if you have listened to the discussion of tricuspid regurgitation, I've said one of the important causes of TR is functional right ventricular failure. And what happens with right ventricular failure is that the right ventricle chamber is dilated, so the tricuspid annulus is also dilated, and therefore there can be a TR. Similarly, on the left hand side, now I'm saying if a mitral valve annulus is dilated, I'll tell you the reasons behind it, but then this would be called as the secondary variety of chronic mitral regurgitation. So let's enumerate the causes here as well. I have enumerated in Western population, one of the most important reasons for development of chronic MR is MVP. Even in the MVP animation, I've highlighted about it. And here I'm talking about is myxomatous degeneration, which is really gonna be a slow process. Then the Ashkoff nodules of rheumatic fever can also contribute to the same problem. It could be infective endocarditis, though obviously at the moment I'm talking about not infective endocarditis of the acute variety, it's a healed variety. Here what I'm saying is the residual damage will contribute to a chronic MR. And the fourth reason is a little atypical one, that is a congenital heart disease by the name of ASD. Now, when we read about ASD, we always think about a left to right sided shunt, but there is a variety of ASD which is very common in Down syndrome and is called as ostium primum. When you go down to the congenital heart disease topic in the app itself, yes, I've discussed the pediatric component also for congenital heart disease, then you will notice that these patients of ostium primum actually have a defect in their mitral valve, which is called as a cleft mitral valve. Now, the importance of knowing this will be that if there's a defect in the mitral valve, LV blood can leak to LA. And if the LA pressure will rise, there is anyway shunt operating from left atria to the right atria. You see, if you compare with ostium secundum, in ostium secundum, there is no cleft mitral valve. So it is LA minus RA pressure, which is about 4 millimeter of mercury. But in this case, the LV pressure will be transmitted to the left atria. So left atrial pressure will be much, much higher than what is present in ostium secundum. So therefore, ostium primum per se has an earlier presentation and is more severe, mainly because of the left ventricular pressure being transmitted to the left atria. So therefore, this is also to be remembered as one of the primary causes of development of chronic MR. Now let's focus on the secondary. You see, my patient, he's having a triple vessel disease. So I had advised him to undergo a coronary artery bypass grafting, but patients being patients obviously went for a second opinion, third opinion, and kept on delaying the procedure. In triple vessel disease, there's a long-term hypoxia in the heart. This hypoxia can contribute to development of ischemic cardiomyopathy. And when I say cardiomyopathy, then the heart will be relatively dilated. And when there's a chamber dilation, therefore, it's no big deal, because after all, LAD is one of the important blood vessels supplying the left ventricle. So the left ventricle chamber gets dilated. The mitral annulus can also get dilated. Let's look at another one. This guy is a big time alcoholic. And you very well know long-term alcohol intake can contribute to development of dilated cardiomyopathy, as a result of which he can either write long-term alcohol abuse, or he can mention the word cardiomyopathy. I mean, if he mentions cardiomyopathy, it will be easier for you. The next one is hypertrophic obstructive cardiomyopathy. Now, this looks a little surprising because traditionally in HOCM we read about banana-shaped cavity, but in HOCM we also read regarding what I'm going to teach, and I have taught in HOCM also. That's a very special finding actually. That's called a systolic anterior movement of the mitral valve. This systolic anterior movement of the mitral valve, usually written in MCQs as SAM, is going to be characterized by the valve movement, contributes to annular dilatation, and therefore there's a secondary variety of chronic MR developing in the patient. A little atypical aspect, so that's why worth its weight in the exam. Then is any patient of chronic atrial fibrillation. Now, atrial fibrillation on the long run will contribute to left atrial enlargement. And when I have a left atrial enlargement, then again, the mitral annulus can get dilated. So the message here is whatever be the pathology on the right hand side, whether it's a cardiomyopathy, whether it's going to be a left atrial chamber enlargement, common thing between all of them is a annulus dilatation that is occurring. Whereas on the left hand side, it is more specific. This part, MVP, myxomatous degeneration, contributing to chronic MR of the primary variety, something that everybody is easily able to answer. So this part will not have any errors in the actual exam, but then there are a couple of aspects beyond that also that I've tried to explain and I would like you to remember. Now, before we go into how the patient will present, we need to look at some aspects of fluid dynamics, and this will help us interpret the echocardiography report of this patient also relatively better. So I'm gonna rather talk about a bit of physics here before you. You can see this can be taken as a representation of the left ventricle. This is the left atria. And this is the mitral valve of the patient, which is defective, because of which you can see some jet of blood is leaking across from the LV to LA because of a difference in pressure. Now, this is the cross-sectional area of the jet of blood, which is in the left ventricle. And then subsequently, you can notice that there is a term that is mentioned here that is called as vena contracta. From the fluid dynamics perspective, I want you to remember that vena contracta is that area of the jet of blood where there is gonna be maximum velocity present. And because of this maximum velocity, I can say that if there is going to be more leakage of blood, or if the severity of the disease will increase, then in fact the maximum velocity will also increase. So from the physics perspective, I want to say that vena contracta is actually the narrowest part of this jet. I'll just draw both with the same color just for you to compare. I've shown the widest part of the jet, I've showed the narrowest part of the jet. Narrowest part of the jet, simple concept of physics. If fluid is going through an area and the area becomes narrow, then the turbulence increases, or the flow rate tends to increase. So here I'm just trying to highlight that the narrowest part of the jet of the blood will be having the maximum velocity. And why that is important is because of the fact that from the MCQ perspective, he can definitely ask you definition of severe mitral regurgitation. So just like you guys are comfortable that severe mitral stenosis would be less than 1.5, very severe would be less than 1, severe tricuspid stenosis is less than 1 square centimeter, and I mentioned regarding these criteria during each of the valvular lesions. At the moment, I'm teaching you what is severe MR, because that will require repair. One of the technical definitions for vena contracta, the magnitude of it, if it is more than 0.7 centimeter, this implies the fact, substantial velocity is present, and therefore there would be a lot of turbulence of blood. Apart from this, because there is leakage of blood from LV to LA, so normally left ventricle should be ejecting blood into the aorta, but here what is happening is that the jet of blood is going to the other way around, in a sense that instead of the LV decompressing into the aorta, the blood is leaking into the LA. Out of 80 ml, as much as approximately 60 ml of blood is leaking into the left atria of the patient per beat, which is very, very substantial. So I'm going to classify this as severe mitral regurgitation and will require a surgical repair. Instead of writing regurgitant volume, he can also write an alternative term, that is a regurgitant fraction. And if this is going to be more than 0.5, which means that out of 80 ml, at least 40 ml blood is leaking. If any of these terms are met or are mentioned in a question, it basically highlights that the person will require a surgical repair and medical treatment will not be sufficient for this person. Also, I would like to mention a few words regarding the murmurs that we see in MVP topic that has been discussed prior to this. I have spoken about mid-systolic clicks and development of a late systolic murmur. But the same patient can get converted into a chronic mitral regurgitation when the murmur will be present all through the duration of systole. So therefore, either is going to call it a holosystolic murmur, But holosystolic as a word is easily decipherable. I mean, you read the word holosystolic, it's relatively easy for you to pick up. So you will notice lots of time literature using the word pansystolic murmur. And I have today also taught you regarding acute mitral regurgitation, which could be occurring due to infective endocarditis or papillary muscle dysfunction, where the murmur that will be present, listen to the words carefully, will be not a late or a pansystolic, but will be rather a early systolic murmur. I am going to draw a shunt diagram subsequently to represent this, but the first two aspects, the late and the pansystolic one, have already been discussed in the previous video. So a new concept has just been introduced, that especially with cases of myocardial infarction, when you read that after MI, the patient is having an early systolic murmur and is having breathing difficulty, which is not responding to decongestants, that implies the fact that there has been ischemic damage not only to the myocardium, but the valve leaflet as well. And which valve leaflet is usually commonly involved? That is, I have already explained to you, that is the posterior leaflet that would be involved. But these three technical aspects that I've just highlighted before you form the crux of the discussion. I mean, once you get these words right that I've underlined in color blue, that means that you will be able to analyze faster in multiple choice questions. Let us now look at how the patient will present and how the disease will evolve. The first clinical feature that will be noticed in these patients will be usually orthopnea. See, when it comes to the mild and the moderate variety of mitral regurgitation, most of the time the patient is able to tolerate it really well. Therefore, most cases that come to our clinical practice are those of severe mitral regurgitation, which will contribute to pulmonary edema, which the patient will not be able to handle. So he is telling me that I could climb the stairs or flight of stairs in my house multiple times per day. I used to get tired, and therefore, as the disease has progressed, his ability to climb stairs has been substantially reduced. And in the later stages, because if the left ventricle is getting involved, then even the right side of the heart will also be getting involved, and in the long run, in severe mitral regurgitation, he might even develop ankle edema, might tell you difficulty in putting on shoes as well. So when I have decided to examine this person, left ventricle failure is anyway occurring, that will affect the right ventricle, because you very well know both work in sync. If the left is involved, then the right will automatically get involved. So therefore, jugular venous pressure in this person will be elevated. The liver span of the patient normally is about 12 to 15 centimeter will be increased. So they will be hepatomegaly, even abdominal fullness, or he can mention regarding abdominal discomfort also. The blood pressure in mitral regurgitation will usually be normal to lesser, especially lesser in severe MR, because after all, blood is leaking from LV to LA. So ultimately the blood going into the aorta will be lesser. Another important finding that could be written would be a palpable thrill at the apex. Basically, the point is that there is so much of turbulence in the heart that when you put your hand on the chest of this guy, when you're trying to localize the apex beat might be displaced from its normal position, because the left ventricle of this patient will definitely enlarge. You see, blood will go from LV to LA, then it will come back from LA to LV. So these patients have a left ventricular failure, and because of the turbulence in the heart, a thrill might be appreciated, and he might even say the word hyperdynamic apex beat. You see, when I say heaving apex, that is what I've described in aortic stenosis. Heaving will be so forceful, the impulse, that it will lift your finger, but hyperdynamic would be just a forceful impulse felt at your finger, but it will not be able to lift your finger. So hyperdynamic apex and the displacement of the apex, I mean, normally the apex beat would be present about 2 centimeter medial to the mid-clavicular line. Here there will definitely be a apex displacement also occurring laterally. So these are some very common findings that can be seen secondary to the left ventricle which is getting affected. And then he will ask you regarding findings of S1 and S2 for these patients. In mitral stenosis, S1 is loud, but in mitral regurgitation, the turbulence will be lesser because there's a defective coaptation of the valves. So this defective coaptation rather decreases the sound. You see, when the valve door is closing, the door is not closing properly. As a result of it, the sound produces relatively lesser. So you will be having a soft S1. And for the second heart sound of this patient, though that is described in S2 part, in the earlier part of the app only, no harm in repeating that information, that A2 and P2 will anyway be having a split. You see, P2 of yours and mine anyway shows variation with respiration. It keeps on moving left, right. So P2 is anyway variable. What's going to happen in this person would be that there will be an early A2. Why early A2? Because after all, the amount of blood going out of the heart of this person is lesser. Less blood will take less time. You see, during the phase of systole, if this is the line diagram that I have highlighted again before you, what is happening in this chap is that the blood is definitely going into the aorta, but a substantial amount of this blood is leaking into the left atria also. So this could be, let me say, 10 ml, 20 ml, whatever. But if the blood is going to leak, let me say 80 ml had to go out, 20 ml leak to the top. So mathematically speaking, how much will go out of here? Only 60 ml. If less blood will go out of the heart, it will take less time. If it will take less time, the A2 will close relatively early. So in textbook, it is just written mitral regurgitation as a early A2, but with the mathematical values, I've tried to explain to you why do you get a early A2, and therefore you can see the two lines are going away from each other, and therefore the special auscultatory finding which is to be remembered for these patients would be a widespread second heart sound. And I've also written the word variable because that will be variation of respiration. P2 component will anyway keep on changing, but A2 is occurring earlier, so that's why the word is wide variable split. I explained that again. The wide is because of early A2 and the variability is anyway because of the impact of respiration. Then in some of the cases, you might even be having a third heart sound, especially with respect to patients of chronic mitral regurgitation. Like if a person is having dilated cardiomyopathy, I've explained that S3 occurs whenever there's a ventricular chamber dilation. So if a person is having ischemic cardiomyopathy or a dilated cardiomyopathy, a third heart sound can develop in these patients. And now we will focus on what is the kind of murmur that will be seen here. And at this juncture, I would request you to take a paper and a pen and try to draw with me so that you can have a better, I would say, memory for the timing of the murmurs in these patients. In the earlier part of the app, I have taught regarding presence of mitral valve prolapse, where what you have is mid-systolic clicks. I've symbolically represented them. The chordae tendineae are lax, they're loose, and they're getting stretched one by one. So the tension in the lax and loose chordae tendineae would contribute to mid-systolic clicks. And then subsequently, there will be a late systolic murmur in the patient. This that is currently shown before you is just before chronic MR will occur. The person is having myxomatous degeneration of the valve leaflets contributing to a late systolic murmur. However, the same patient after a couple of years, if the treatment is not taken, medical treatment is not taken, follow-up is not done, then definitely high chances of deterioration will occur. So I'll hand draw this before you as well so that you can understand how a pan-systolic murmur will be evolving in the same patient in the long run. Now, in the patient, what I've shown is, and deliberately changed the color also, just to say that the murmur is present all through the duration of systole. So that's a pan-systolic murmur that is occurring at this movement. And then there's another important concept that he will utilize because he knows the fact that you will be able to answer this holosystolic murmur, pan-systolic murmur. So the concept is that after all, the blood is leaking from LV to LA. It could be 5 ml, 10 ml, 20 ml, whatever. But that blood that goes into LA, that is not going to go, all of that is not going to go back into the pulmonary circulation. No, it will definitely contribute to pulmonary edema. That's okay. But what is going to happen to that blood? Let me say 10 ml went into the left atria. What's going to happen to that blood? That blood will ultimately have to flow back. It will again have to flow back into the left ventricle, though the left atria is dilated. Capacity is increased, but what's going to happen to that blood? It's not going to stay there. That blood will have to finally come back to the ventricle, and when that blood is coming back, because the volume of blood now coming into the left ventricle will be increased. Why? Because you are having a normal amount of blood also coming, endostolic volume, plus this extra amount of blood also coming. Like endostolic volume, we very well know. I am saying in MR, the end diastolic volume will be increased primarily because you are having a normal routine filling, plus this blood that went from LV to LA also has to come back. So in the end result, because of the turbulence created by this extra blood during the phase of diastole, you will be having a flow murmur also present in these patients, and this flow murmur that I've drawn before you is a mid diastolic murmur. Why that is important is because mid-diastolic murmur has been told to you for mitral stenosis. No, I've told you in MS there will be loud opening snap and then there's a mid-diastolic murmur. But now I am teaching you the fact that even in mitral regurgitation you will read a mid-diastolic murmur. But why is this happening? This is not because there is a problem in the mitral valve with respect to the inflow. It is LV blood leaking to LA during systole. But during diastole, whatever blood that went up has to come back also. No? That blood which is coming back is extra over and above what is present in you and me, so it's going to create a turbulence, and therefore in the MCQ he will deliberately mention mid diastolic murmur in mitral regurgitation of the chronic variety. Yes, that is true, that will be present. This is extra amount of blood that had initially went just in the phase of systole prior to this from LV to LA. In contrast, when it comes to patient having acute mitral regurgitation, you see the damage is not complete at the moment. One of the leaflets is defective, one of the leaflets is still functioning. So what I will say is that because the infrastructure is still performing at a suboptimal level, it's not performing at an optimal level, it's performing at a suboptimal level. So the murmur will definitely be present in the early part of the systole and then will definitely die down. So this that I've shown is called as early systolic murmur. From this diagrammatic representation, which I presume you would have drawn before me, all the three concepts are important, but the one that I have highlighted, the flow murmur concept in chronic MR, is definitely to be remembered. The three diagrams are for, the first one is for MVP with myxomatous degeneration occurring, then it gets converted into the chronic variety of MR. But if a person is having a mitral regurgitation of the acute variety, this is primarily because of papillary muscle dysfunction due to MI, because endocarditis has now become relatively less common. I mean, we have good quality antibiotics, we take good care, we give prophylaxis during invasive procedures if a person is a high-risk patient and is a candidate for prophylaxis before, let me say, a dental procedure or undergoing a GI surgery. I mean, there's a list that I've discussed in infective endocarditis topic of patients who would be requiring prophylaxis before they undergo any invasive procedure, because otherwise infective endocarditis, if it progresses, the existing valve lesion can definitely worsen. But these are a couple of important aspects which I definitely would like you to hand draw. And now we introduce one more technical aspect which is important from the perspective of the radiation of the murmur. You see, in medical college we are always taught this fact that mitral regurgitation murmur of the chronic variety always exhibits a radiation to the axilla. You all know that, nothing great in that. But what I am trying to say here is that when you read about aortic stenosis, again in the app or in the textbook, you will always read that there is a ejection systolic murmur, also called as a crescendo decrescendo murmur. The murmur will be peaking in the middle of the systole. Ejection systolic is different from early systolic. I mean, the name itself is clear. Ejection systolic is going to be peaking in the middle of the systole. So one of the reasons why would you be having problem in aortic stenosis is because the orifice is narrow. When the left ventricle will try to decompress and send blood into the aorta, because the opening is narrow, there will definitely be a turbulence that would be developing. So this ejection systolic murmur will usually be best appreciated in the right upper sternal border, and the murmur will be exhibiting a radiation to the carotids. We all know this, that aortic stenosis murmur will always be radiating to the carotid. So I have also explained carotid thrill present in these patients. But now what I'm adding is that in aortic stenosis, there is another component present, which is that because of the high flow, there can also be vibration in the cusps. See, there are two aspects which I am trying to explain here. One, I'm saying orifice is narrow. So when the blood goes through that narrow orifice, there will be noise. So the noise is primarily because of the turbulence of the blood. But second, what I'm saying is this can also set up vibrations in the valve cusp of the aortic valve. These vibrations which are present in the cusps per se, or vibrations of the cusps that are present, can result in the noise being radiated to the axilla, and therefore there's a possibility that you might think that you're hearing a murmur of mitral regurgitation radiating to the axilla. You see, after all, the point is in MR, the murmur radiates to axilla, straightforward fact. In aortic stenosis, I am talking about radiation to two areas. One, I'm saying the murmur will obviously radiate to carotid. That is undisputable. But there is another component present which may or may not be present, but if present will cause confusion with whether you are having a murmur of MR radiating to axilla, or is it the vibration of the cusps of the valve per se, not the turbulence, not the jet of blood, but the vibrations of the cusps which are causing radiation to the axilla. This can mimic mitral regurgitation, and therefore there's a special name given to this confusion that comes up, and that would be called as Gallagher-Din phenomenon. So from MCQ perspective, this name is to be remembered simply. Gallagher-Din phenomenon simply implies the fact that the murmur of MR which relates to axilla can be confused with a murmur of aortic stenosis, which is definitely a ejection systolic murmur, but a component of this can still be relating to the axilla. Why is because of the vibration of the cusp per se. Next, I'm going to teach you regarding what is going to be the workup of these patients. So the first investigation that I'm going to do is a ECG. And since the left atria is going to be dilated, it's going to take more time for the current to go across the left atria. Therefore, the normal duration of the P wave is approximately 120 milliseconds. But the way I have shown this particular P wave, there is a cleft present here. Why? And why the duration is more than 120 milliseconds is because the left atria is bigger than normal. So the current will take more time to go across this enlarged left atria. If the patient will develop pulmonary artery hypertension, then even P pulmonary component will come up, but P mitral will be present initially because of LA enlargement. Now, this will also contribute to a radiological finding. You see the enlarged left atria. The left atria does not form the left heart border, but the enlarged left atria will push the right atria. Right atria is initially normal. It is the left atria which is congested. So the enlarged left atria will push the right atria, contributing to double atrial shadow developing in a patient, or it might be written double atrial contour. In fact, this has been asked in theory. You can call it radiology or medicine. The question said, what is the cause of a double atrial contour? The cause is an enlarged left atria pushing the right. This definitely will contribute to cardiothoracic ratio being more than 0.6. I mean, you very well know that in pediatric age group it is more than 0.6. For adults it would be value more than 0.5. so since I mean, lots of time they can ask pediatric mitral regurgitation due to rheumatic fever, that's why I initially said 0.6, but for adults it's obviously more than 0.5. Because the atria is enlarged, therefore the carinal angle will also be varied, or rather be increased. You see, carinal angle normally would be about 60 to 70 degrees. In this case, the carinal angle will be increased. Why? Because the left atria is present right between at the carinal angle. You see the trachea is bifurcating into the two, and this is the site where the LA is present. So if left atria will show a dilatation here, it will splay this angle, and therefore you might be having another radiological finding coming up that is called as walking man sign. So two important aspects which I want you to remember from radiology: double atrial shadow is enlarged LA pushing the right atria, and walking man sign is again a feature of enlarged left atria, but this time it is going to be the splaying or the increased carinal angle. I'll be doing a echocardiography, a transthoracic echocardiography, to confirm the diagnosis, and there would be a regurgitant jet that will be demonstrated going from LV to LA. I have already talked about the concept of vena contracta, which will be having a substantially high velocity, and also the size of it. I mean, if it's mentioned more than 0.7, then it indicates a severe variety of mitral regurgitation in a patient. Now let's look at what are the treatment options available before us. There's a possibility that he might describe acute mitral regurgitation deliberately, because you see, when you read about the chronic variety, you can answer about a valve repair being done. Acute mitral regurgitation will cause acute decompensated congestive heart failure. It will contribute to acute pulmonary edema, and well, this pulmonary edema can be so severe, the pink frothy sputum that's occurring in the patient might be so severe that the patient might die before you are able to do something. So what is that something that you will do is, one, anyway give diuretics to this patient, that is furosemide, and the second thing you're gonna do in this guy is use sodium nitroprusside. Yes, sodium nitroprusside. We traditionally read about nitroprusside for management of high blood pressure, especially with hypertensive emergencies. Malignant hypertension is where we tend to read about sodium nitroprusside. But today I'm talking about nitroprusside in heart failure also, because this drug will per se contribute to a decrease in the afterload of the heart. You see, the heart is anyway not being able to pump the blood because all the blood is leaking from LV to LA, or majority of it. So I want to reduce the load on the heart so that it is able to perform relatively better. So decongestants and drugs that lower the afterload, and obviously some component of the preload, will definitely be beneficial for this patient. Let us now compare what are we gonna do for chronic MR. In multiple choice questions, because they have a habit of using short form, so he might write the word MVR capital small p, or MVR. R would basically stand for replacement and RP would stand for repair. So our first objective will be to try and preserve the endogenous valve of the patient. So we'll try for a repair. If a repair is not possible, we'll try to go for a replacement. And I mean, sometimes there's a possibility that the valve is totally gone, especially post-infective endocarditis. Then we might even have to deploy a prosthetic valve. And when would you be doing this or when would you planning this? Then I just want to add that in chronic mitral regurgitation, only of the severe variety would we be planning these steps. I mean, we'll plan a repair, if not possible, then a replacement. And I mean, with the prosthetic valve, obviously there are challenges present. You have to use anticoagulants in the patients subsequently. So nowadays we are also having a transcatheter approach available. So you will read about this brand name Mitra clip. Mitra clip simply means that we are going to deploy a clip which is going to help in approximating the valve leaflets together. That prevents the leakage of blood, and this would be deployed. I mean, this would not involve any open heart surgery. This would be, I would say, a cath lab based procedure. So a transcatheter mitral clip might be deployed, which will help in reducing and even preventing the further deterioration of a degenerated valve. This is definitely advancement because cath lab procedures are gradually replacing, I would say, the gross surgeries that we tend to see in cardiothoracic vascular surgery. Most of the time, it's interventional cardiology which has gone and has progressed by leaps and bounds and reduces the hospital stay of the patient. So anyway, wherever possible, we try and prefer a catheter-based approach. Because these patients will be having atrial fibrillation due to structural damage to the left atria, so we will have to use warfarin. And because majority of cases in India, especially children with rheumatic heart disease, tend to have MR. You see, adults or after 18 years of age you have MS, but in pediatric age group it is MR that is present. So what I'm saying is that if it's a rheumatic etiology specifically, then in atrial fibrillation we should be using warfarin, and novel oral anticoagulants are not to be given. In fact, this is itself a MCQ statement, so do give importance to this while we are at the end of the discussion, that atrial fibrillation, especially with rheumatic etiology, it is warfarin which is to be given as an oral anticlotting agent. We definitely have lots of advantages with novel oral anticoagulants or directly acting anticoagulants, in a sense that they have less chances of CNS bleeding, but they have not been tested, especially with the rheumatic etiology. I want you to remember the fact that novel oral anticoagulants are contraindicated in two scenarios. Scenario number one would be whenever he mentions regarding rheumatic etiology coming, like there is a atrial fibrillation. This atrial fibrillation is associated with mitral stenosis. It could be mitral regurgitation in a child. But the reason why this is happening is rheumatic. They have not tested actually in this subset of patients. They said that the chances of development of stroke are anyway high in these patients. So we want to persist with warfarin rather than trying to subject these patients to newer drugs per se. The second contraindication is mechanical prosthetic heart valves. I mean, if a person has like in a patient of severe mitral regurgitation, you decided to put up a metallic mechanical prosthetic heart valve, then you very well know that with a mechanical metallic heart valve, we will be requiring anticoagulation for a long duration. But he says that do not use novel oral anticoagulants, rather use warfarin. I'll just show you data also, which actually was asked in the AIMS exam. So I'm just giving a reference here from the European Society of Cardiology, and even the American Heart Association says the same, that when it comes to novel oral anticoagulant agents, they definitely have advantage with respect to not having the requirement of doing a coagulogram again and again, having less chances of CNS bleeding, unlike warfarin where the chances of bleeding are more. But there are two red I would say zones or red flags for using novel oral anticoagulants. One is mechanical prosthetic valves, and second is moderate to severe mitral stenosis of rheumatic etiology. And I've already explained, I mean, in pediatric age group, it may not be MS, it might be even MR in a patient, but do answer NOAC not to be given, because traditionally we are always praising novel oral anticoagulants, but these two situations is where I want you to remember that novel oral anticoagulants are definitely off the radar, and this has been asked especially in INISET in 2021. So from the recent questions perspective, this is anyway important. So keep learning new facts, guys, on a daily basis. The more you learn, the more you are able to perform better. And I think that if you will keep on doing 1 to 2 lectures a day, not a big task, I would say, but if you keep on doing it on a regular basis, you will definitely be able to complete your syllabus, and you will be able to get your questions right with a good amount of strike rate. Just fact is, negative marking has to be reduced, analytical skills have to be used, and that comes with practice. Your eyes will automatically start going to the right answer. I'm not saying that you want to try it right from the beginning. I mean, try to exclude questions, but with practice, you develop that skill that you are able to strike off the options and you are able to focus on the correct answer. So keep hammering, keep the focus on, keep learning, and you will do great. Take care.